a content specialist for Child Welfare Information Gateway and a project coordinator for the National Resource Center for In-Home Services. On behalf of the National Resource Center for In-Home Services, we welcome you to the Evidence-Based Elements of In-Home Services webinar. And before we get started today, our operator Noah will cover the logistics of today's webinar.
Thanks, James. I will explain a few of the audio and video capabilities for this webinar. We will leave time at the end of the presentation for questions. There are two ways you can ask a question. In the control panel at the top right corner of your screen, there is a feature that allows you to raise your hand if you want to be recognized or type in a question in the chat box. Feel free to use those features at any time. If you would like to ask a question, please signal by pressing *1 over the phone on your telephone keypad. If you're using a speakerphone, please make sure your mute function is turned off to allow your signal to reach our equipment. A voice prompt on the phone line will indicate when your line is open. Please state your name before posing your question. Again, press *1 to ask a question over the phones. Please note that this webinar is being recorded and will be available on the NRC In-Home Services website. If we don't get to your question, a question and answer document will be developed and posted on the NRC's website along with today's PowerPoint presentation. Now I will turn the meeting over to Lisa Diano, the Project Director for the NRC for In-Home Services. Lisa?
Thank you, Noah. Welcome, everyone. I'm very excited to be able to present this webinar to you today. Looking forward to sharing what has been a journey for the National Resource Center for In-Home Services for over 4 years as we looked for what works in evidence-based in-home services. Just a little bit about us. We are a service of the Children's Bureau and a member of the Training and Technical Assistance Network, and we were funded to be a national center of child welfare expertise on in-home services, which are designed to keep children safe and well at home and to prevent their placement or reentry into foster care. You have, as you know, a number of resource materials for today. I think I may have overwhelmed you with resource materials for today. But what I wanted to do was to give you as much background, as much information as possible, and as much detail as possible, knowing that some of you will share this with evaluators, share this with decision makers, and others of you will just want the highlights. So I've given you a variety of things. One is a brief that describes the core elements approach to in-home services that we've developed. There's another shorter piece that talks about in-home services that are listed on the evidence-based registries. You have a table. In fact, you have two tables. One is the 5 evidence-based models of child welfare in-home services. You also have a matrix of the core elements. And all of those things should be helpful to you as we go through the webinar. And there will be times that I'll ask you to refer to one of those pieces since they're pretty detailed and some of those things don't fit very well on a PowerPoint slide. All of this material are going to be archived on our website, so if you want to, you'll know you can always refer back to it. So to begin with an overview of today's webinar, we'll start with a working definition of what we mean by child welfare in-home services. Then we're going to look at evidence-based elements of in-home services that are related to the critical child welfare outcomes of safety, permanency, and child and family well-being. And for in-home services, when we think about permanency, we think about family stability. And of course, preventing placement into foster care. Excuse me. After we look at elements, then we're going to look at 5 evidence-based models that can be adapted to child welfare in-home services. And then we'll finish off with some recommendations. And these recommendations will be based on our almost 5 years now of training and technical assistance across the states and tribes about how states might think about implementing evidence-based elements or evidence-based models. So it's a big agenda. I'll be stopping after each of the 3 major sections to take questions. So just a bit of background. At the beginning of our project, which we started in late 2009, we were charged with conducting a nationwide assessment of what works in in-home services. And to that end, we conducted many interviews with state child welfare managers. We did literature searches. We looked very, very carefully at both rounds of the Child and Family Service Reviews and to look and see what what might be better performing states and in-home services, if there were any commonalities. We looked at state plans. We found that there were large areas where there wasn't much at all, and we really began to develop practice briefs. So it was a very extensive search, and so I'm sharing with you mostly literature search today, but also what we've learned from interviewing various state actors and just the general research we did for the nationwide assessment. So I want to start out by saying that this is something you probably know, which is that when we looked at how states were doing, what the literature was saying, it was very clear that there was no one-size-fits-all model of in-home services. States who were doing fairly well in in-home services had a variety of approaches. There weren't as many commonalities among those states as we expected to see. So we also looked carefully at the literature, and what we saw there was that it was a mixed bag. Those of you who've been around this field for a while know that in-home services research really kind of took a hit back in the 90s. It's possible that in the field there was some overpromising about the results of intensive family preservation. At any rate, there was kind of a swing in the pendulum toward away from in-home services, and certainly away from in-home services research for a while. And so, frankly, the literature for a while was sparse, and it's really taken a resurgence lately, but I would have to say that there's still much, much more to do. So as we looked at the outcomes literature in in-home services, we really did see that there wasn't one thing we could point to that we could tell states, this is how you should go for in-home services. Okay, I want to talk a little bit more about the definition as we found of in-home services. And so the target population, the best way to think about child welfare in-home services is to think about the target population and the goals. So the target population, as we have defined it for this purpose, is families who have come to the attention of the Public Child Welfare Agency because of alleged child maltreatment. So in general, it's what we would consider open cases. However, those can include families who are being put on that family assessment or differential alternative response track, as it's called. In most cases, those families are considered open cases, at least for a while. So it's basically that population. Just to distinguish it, we didn't focus on services that were primarily what we would call secondary prevention, which is addressing families who have risks of child maltreatment but haven't actually come to the attention by virtue of a report to Child Protective Services. So beyond the target population, the goals of child welfare in-home services are really three. The first is to stabilize the family, also to ensure the safety and well-being of the children. Perhaps I should have said that first, safety being the primary function of Child Protective Services. And the third is to prevent placement, if possible, or to prevent re-entry into foster care as long as the children can remain safe in their homes. One of the things that sometimes confuses folks who aren't maybe in the field, we talk about in-home services, and they immediately think, oh, that means services that are only delivered in the home. But we have a broader definition. In-home services really refers to where the children are in their homes, but the services can be delivered in the home or in community or office settings. In order to be considered in this study, we looked at services that were going to be delivered to a family, so at least a caregiver and a child. Now, that doesn't mean that individual components of the service might be offered to just a child or a caregiver, but the idea was that this wasn't sort of a clinical intervention to a particular one client, but rather to the family. Also, in-home services can be mandated, but in most cases they're, I guess we would say, technically voluntary. Most of us, we talk about voluntary, but we have to sort of realize that in child welfare there may not really be such a thing as voluntary services once you've been identified. Now, we've excluded from this analysis most, as I've said, most family support services. There are a few things we'll talk about that really are sort of crossovers. They've been identified specifically as interventions for neglect, but for the most case, the secondary prevention services are not included in this analysis, nor are group-based parent education or clinical interventions, such as a trauma treatment or something like that. One of the things that we really wanted to focus on were services or elements that could be brought into what we're calling a core child welfare service. In other words, a model or service that could function as the primary state intervention or could be readily adaptable. So something that either the state or county child welfare worker could implement, or if you're a state that does primarily contracting out, that the primary worker, the one who would be working most closely with the family, could use that intervention. Sometimes the models we looked at, in most cases the models were really very holistic and covered all the functions of a child welfare worker. In one or two cases, they would be simply part of that intervention, but still could be considered a pretty substantial part. And I'll bring that up when we get to that particular service. So I guess I'm going to begin with maybe the weakest news we have, and just get that out of the way, because I know that some of you face skeptics about in-home services, and let's just get to that right away. The outcomes research on in-home services is really a mixed picture, and what I mean by outcomes research is when you look at over all the studies that have been done in in-home services, how do they fare on the outcomes of either safety, which is generally considered the not having repeated maltreatment or repeated reports of maltreatment, for permanency, avoiding placement, and for family well-being. And really, there's been very little work on the area of family well-being. So most of it has been on either placement prevention or reduction of child maltreatment reports. When you look across all of the studies, what you find is we got down to 12 studies that were that really qualified as the top studies in the field, and you can see that 7 out of 12 of those found that in-home services reduced or delayed rates of placement. A group of those studies are with intensive family preservation, and so that probably is one of the biggest pieces of news that we had in our field in the last 5 or so years, is that intensive family preservation service, which is along the lines of the home builders model, has finally been recognized as an evidence-based practice. And so most of the studies that we're talking about did find reduced or delayed rates of placement in intensive family services, but some of the studies also included the non-intensive services. With respect to subsequent maltreatment reports, it's overall, over all the studies, there has basically no significant difference between the programs that were considered, the studied programs, and what they called services as usual. And that's really one of the sort of methodological difficulties in our world, is that we're not randomizing treatment for children in most cases. We're not giving one group of kids services and the other group no services. So we're always comparing the intervention that we want to study against what they call services as usual. And those of you who offer services know that services as usual will often look a lot like the special services. So it's really hard to compare those two groups and to find significant differences. One of the things that happens is workers are really reluctant not to put people in the treatment group. That's the most resources people want to do that. Another reason is that your practice might be influenced with all your families by the model that's being introduced. So there's lots of reasons that services as usual versus studied programs don't come up with a significant rates. I guess another one that we must think about is that when we have a family under surveillance, you may end up with more subsequent maltreatment reports just because more people are looking. So having said that, within the studies, even where, within the studies that did show reductions in child maltreatment, certain components or approaches were looked at, and it was determined that those were more likely to result in reductions in maltreatment. So let me say that again, because it's a little bit complicated. Even though there are some studies that don't show reductions in maltreatment, among the studies that do show reductions in maltreatment, there are differences in those populations or in those services among the ones who did better and the ones who did less well. And that's what we're going to focus on in our elements research. What are those components of in-home services that can contribute to reductions in maltreatment? Okay, the final thing I want to mention about outcomes research is really good news. You know, we're all focusing a lot more on child well-being and family functioning. And in-home services, even though we don't have that many studies that have looked at it, we see very strong positive outcomes. So as you are, as you begin to work on your next round of federal monitoring, as you're thinking about quality improvement measures, it's really important to be thinking about measuring child and family well-being in the context of in-home services. I think that's where you're going to find some stronger outcomes that you'll be happy to notice. All right, so moving on to consider our evidence-based approach. As you know, there's demands all over the place for evidence-based practice. Legislators want it. Private funders want it. The federal government provides demonstration money for evidence-based practice. Everybody wants to know now, is this practice evidence-based? One of the difficulties is that, in general, evidence-based practices have tended to focus on specific problems and specific populations that are very carefully screened out. And that's not something that's easy to do in child welfare services. And so it doesn't translate very well to a statewide practice model. We found in our technical assistance to states that most states were not looking to scrap their existing models and just start over and adopt an evidence-based model. Now, some of them had opportunities to introduce evidence-based models either because of pressures from inside, or they got special money to do something. The Title 40 waivers provided money to do evidence-based practice, pilots, demonstrations. But most states are looking for ways to enhance what they're doing. And so what we wanted to do was offer help for both of those things, either looking at what you're doing and enhancing it, looking at your contracts for services and enhancing those, or going ahead and adopting a full-blown evidence-based practice with fidelity. We wanted to provide guidance for both of those. So we used, in order to do the former, we used what we're calling an elements methodology, and this is similar to what Richard Barth and his colleagues have been working on in other fields, such as parent education. This was the elements methodology looks at the empirical evidence in studies that examine the associations between certain components of services and outcomes. Now, we began really with we started out with a really good review of studies by Mary Berry, which will be cited in the back of this presentation. And then we sat down with our team, and we just basically thought, okay, if a state came to us and asked, what would you want an ideal in-home services program to look like based on our knowledge and experience and the research we know about, what would we want it to look like? And so we developed a list of 15 what we called core elements or service components. And then we began systematically to look at the studies to see if we could find any evidence for how they affected the outcomes of safety, permanency, and well-being. And then another thing we did was we identified 5 evidence-based programs, and we tested the relevance of these elements. Did these evidence-based programs have these elements? If they did, it might mean that we were on the right track. And so that's the information we're sharing for you today. So these are the key elements that we we identified, and now I can tell you that we found the evidence for them. So here they are, and you have, this is where I'd like you to turn, if you can, to your table that's entitled Core Elements of Child Welfare in Home Services. But I wanted to put all the elements on one slide for you. I'll just quickly go through them. Family-centered strength-based case planning, which includes family involvement, family decision-making, culturally competent models, targeted services, I'll talk about that more in a minute, safety planning and safety management, comprehensive assessment of family strengths and needs, an emphasis on family engagement, voluntary services offered at the time of assessment as essentially an early engagement strategy, matching the services to the family, individualization. At the top of the page then, high-quality worker-client relationships is a key element of quality in-home services, as is case coordination. And case coordination refers to the process by which a worker makes sure that all the pieces, when families are involved in other systems such as substance abuse, mental health, criminal justice system, that those pieces are coordinated so that the family can make the most use of those resources. Another key element is that the intensity and the duration of services fits the family's needs, and we're going to talk more about that. Another element is the availability and use of problem-specific interventions aimed at specific issues. So, for example, substance abuse, mental health, domestic violence would be the three classic ones. They could also be the specialized clinical treatments for trauma. Another key element is direct coaching or teaching, and that's by the worker, and teaching problem-solving skills. So direct teaching and coaching includes, most specifically, parenting skills, not necessarily parenting education, but hands-on, in the home, ways of teaching families how to do things that make them effective parents. Another key element is accessing community resources and increasing the family's social support. And last but not least, programs that have have the availability of concrete services, and by that I mean funds for emergency needs, housing, transportation assistance. Those programs tend to have better outcomes. Now that's the big picture. I'm going to get into details in a minute, but I want to now, I'm going to switch the slide and show you how the associations between these elements and outcomes. And if you look on your table, you will see the supported outcomes are listed behind each element, along with citations to the evidence base. In your core elements, you have a document called the Core Elements Approach to Child Welfare in-Home Services, and at the back of that you'll find all the references to those articles. Okay, so here are the key elements related to safety outcomes. And I apologize, those of you who are looking onto a handout, apparently something happened when you printed out your handout, so not everything comes up. So what I would ask you to do is, since you know everything is going to be on these tables, that you can relax a little bit and just think about it. All right, safety outcomes. Family-centered approaches are related, statistically significantly related to reduced maltreatment and subsequent referral. How did the researchers find this out? They looked at a whole variety of studies that had, and they were able to find that the ones that had more family-centered approach had stronger outcomes in reduced maltreatment. Okay. The next element highlighted in red that is related to safety outcomes is the targeting of services. And that one's a little bit more complicated to talk about, but the services that are targeted to specific populations basically have defined the population that they want to serve. And so the best example of that would be intensive family preservation services that at least are attempting to target families that are at risk of placement. That's probably stepped right into it because that's actually been one of the most difficult things to prove. But maybe another example might be, a better example might be substance-abusing families. Studies have shown that both intensive and non-intensive services are less effective with substance-affected families, which suggests that there needs to be a special service that is targeted at those families. Okay, and so where there were specific targets that, according to family characteristics and service characteristics, you had better safety outcomes. Another good, significant positive association for reductions in maltreatment and subsequent referral is having done a comprehensive assessment of family strengths and needs. Another one is programs that have a strong emphasis on family engagement. I'll be talking a little bit more about that later. Another element is matching services, individualizing by the family, matching the services to the particular family. Others you can see on the right-hand side, case coordination, the intensity and duration fits families' needs, problem-specific interventions, direct teaching and coaching, and concrete services. All of these are related to reductions in subsequent maltreatment. Now, the elements that we found correlations between the element and placement prevention are listed in blue. Just give you a chance to look at that for a minute. The culturally competent models comes out in this one. There was a specific study that looked at a culturally competent model of intensive family preservation had better outcomes in reduction of racial disproportionality in placement. That wasn't the only study. There have been other studies that show the culturally competent models to be more effective, but this one in particular came up in the placement prevention category. Here are the key elements that are connected with improved family functioning. And you see there's quite a number of them. And I put all this together in a table for you that you'll see in just a minute. Here are the key elements that are associated with improved child well-being. Now, I said from the beginning that there haven't been many studies that have specifically looked at improved child well-being with respect to in-home services. And so that I think it's important to note, it doesn't mean that these other elements wouldn't be connected to improved child well-being. But there just hasn't been the research that specifically looked at child well-being as an outcome. But case coordination, which when you think about the system of care model, would be a great example of case coordination that working toward improved child well-being. And then intensity and duration. So you see, going back, family functioning, we have, now the other thing is to consider family functioning might very well incorporate some child well-being aspects, but there wasn't a specific measure of that. Okay. I'm going to show you the overall table in just a minute, but I really, since engagement is so important, I wanted to do a little bit more specific talking about engagement. There were times, frankly, when we were doing this work, especially in interviews, when we thought, over and over we just kept hearing it's about the relationship between the worker and the client, and we thought maybe we should just put that on our website. It's all about relationship. We're not there with the research yet. We can't absolutely prove that. But I can say that we're, across all human services field, worker-client relationship does come up pretty high. Family engagement is how we've tended to in our field, to think about. And how is that defined? Oh, boy, it's defined in a variety of ways. Three major ways it gets defined and measured in the literature is the collaboration of the family with setting case goals. So the actual developing of case goals. And that the classic way of collaboration would be a family team meeting, but it could also be through a solution-focused, strength-based process with family members. outside of a family team meeting setting. Another way family engagement is defined as compliance with case goals, right? Did they do what they were supposed to do? Did they show up? And then active participation in services is another way that family engagement has been defined. Just to kind of, Yachmanoff has done a little bit more fine-grained analysis, and so when you think about what goes into a family member's decision to get, really engaged, here are some of the factors: openness to receiving help, expectancy, perception of a benefit, investment. We talk about ownership of the goals, and a working interpersonal relationship with a caseworker, which is often marked by good communication and trust, and of course mistrust is negatively related to engagement. I specifically brought up engagement because so we know that the big outcomes that we're looking at are safety, permanency, and well-being, right? But there also were a number of studies that looked at elements and how they related to improved family engagement. So that's kind of I guess it would be an objective. It's not the final outcome, but if we want engagement, which I know that many states, have really focused on that, how do we improve engagement? These are the elements that have been shown through research to be associated. Family strength planning, not surprisingly, right? Family decision-making. Targeted services that are really targeted to the problems that the families are having, are more likely to result in more participation. So when you see those parentheses, that's the measurement that was used for that specific study, those studies. Voluntary services offered at time of assessment. So sometimes people get a little confused about that. What do I mean? I mean that even before the assessment is completed, even before, if this is a state where you're making a finding, the family is offered an opportunity to participate in services. That can happen in a variety of different ways. Some states use liaisons where that reach out, for example, substance abuse or domestic violence services. Other times it's or just a referral made, some way that the family can get engaged because that moment of crisis presents a window of opportunity that you don't want to miss. Intensive family preservation services get involved really early too. So, but this one we specifically focused on voluntary services. Okay, other elements that are associated with improved family engagement include the high-quality worker-client relationship. Having the appropriate intensity and duration to fit the family's needs is also related to worker-client relationship. And a lot of that work comes from Mary Ann Berry, who basically comes down to, in her work, it's direct contact, and it's the amount of contact that a worker has with a client. And the more contact, the more likely to have a strong worker-client relationship. That kind of makes sense, doesn't it? It's not only about building trust and just being there, showing up, having an opportunity for that relationship to develop. Another element associated with improved family engagement is working to increase the family's social support, and that is related to the measurement of collaboration. So the more social support a family has, the more likely they are to collaborate in the goals, and that's a great example of the kind of work that folks are doing when they look at family team meetings. Engaging a team makes it easier for a family to participate in service planning and setting of goals. And the availability of concrete services. This one comes up, it's quite interesting. The early provision of concrete help to meet families' basic needs is associated with higher ratings by the family and of the worker-client relationship, along the lines of my worker knows how to get things done, my worker is there for me, I trust my worker. So it's actually not only helpful to get the client focused on the change issues, but it's really just a great way to build relationships. And it makes sense, doesn't it? And so often, yet, there are such limits on concrete services, but concrete services can be really, really helpful in a variety of ways. So I tried to put this all together in a table, just one place where you could see this. And one of the things I wanted to do with that is just to sort of highlight the different ways in which different kinds of outcomes. And I suppose if I were, we're thinking about, well, where do I want to focus my energy? I'd be, I could look at that and say, gee, some of these areas, really show some great benefits in different areas. So all of you have this PowerPoint slide. I know that's not going to show up very well in your handout, but you can all print that off and keep that. That's just kind of a shorthand version of what we've been talking about. Okay, I think I'm going to stop now and take some questions. So Noah, do you want to open up the line for questions?
Yes, and if you would like to ask a question over the phone, once again, please signal by pressing *1 on your telephone keypad. If you're using a speakerphone, please make sure your mute function is turned off to allow your signal to reach our equipment. A voice prompt on the phone line will indicate when your line is open. Please state your name before posing your question. Again, press *1 to ask a question, and we'll pause for just a moment to allow everyone an opportunity to signal for questions. Once again, that's *1. And we have no questions over the phone at this time.
Okay. All right. I hope I haven't just overwhelmed you.
And Lisa, we do have one over chat that I can go ahead and ask now if that's
sure.
fine.
Yes.
And the question, it's about the family engagement defined. It appears to put much of the emphasis on what the family factors are. And the question is there research on helpers factors?
Oh, yes, there are some. That's a great, let me just, for this, I'm going to turn to my research document and talk about that a little bit. Well, I think one of the things does suggest that it on the worker side it's showing up. It's actually being there often enough to form a relationship. So that's an important thing. Elements of the relationship that really are, it's a partnership. It's a two-way street that have come up in the research have to do with calmness. It's an interesting measure. A sense of open-mindedness from the worker's point of view. Let me just look and see. I want to be very precise. I don't want to just flexibility on the worker's part. That's been something that's been shown to be associated with better outcomes. Non-judgmental attitudes. And again, frequent contacts. The other thing that I wonder about is the connection between, and even though I see it's not on this chart here, but the connection with teaching and coaching. The idea that you would be in the family's life showing them how to do stuff. I can't prove that because yet, but certainly you're not going to be able to that is one way to form a relationship. I guess I would just say that. And again, intensity and duration, so it's not just a matter of how much, being there more often, and then also maybe being there longer. Okay, any other questions?
And yes, actually, we did receive a question over the phones.
Great. Go ahead.
I'm sorry, my name is Nidia Denise. I just want the other person to repeat the question, but through your answers, I got it. So thank you so much.
Okay, sure. Thank you. Any other questions?
We have no further questions over the phone.
All right. Well, we'll have a couple more opportunities. So I wanted to, before I move off of elements, I wanted to talk about safety planning and management. If you were looking, you didn't see a lot of associations on this element and specific outcomes. And it's basically, we just don't have the research yet to show that have specifically focused on safety planning. Now, we do have research on comprehensive assessments, which would obviously include safety issues. But this notion of the specific idea of safety planning, we just don't have the research on it. There are a number of models that, for example, intensive family preservation would be a good example of a well-researched model, where there's a lot of attention paid to safety. There's also a lot of surveillance. In other words, folks in the home several times a week, 8 to 20 hours a week in some cases. So when we think about what are the elements of safety planning, certainly you can imagine that, well, and we know that there are programs that do focus a lot on safety, but the research just hasn't been done yet to show that specific correlation. We didn't take it out of our chart because, as you know, it's a key outcome. You can see, CFSR's items 3 and 4 keep doing regular assessments and putting safety plans in place are key items. I wouldn't recommend an in-home service program that didn't attend to this, but we just don't yet have the evidence. And there are lots of different ways to go about safety planning and management. You can see some of those at the bottom of this slide. Okay. So we've looked at the elements, and now I want to turn our attention to evidence-based models of in-home services. And so what I mean by evidence-based models is that they have, the model is a specific model that it's very well documented, and that it's been studied to determine whether, whether the outcomes, what the outcomes are. And we identified 5 models that really fit very well with child welfare in-home services. And there you see them on the slide. Intensive family preservation services, home builders being the most frequently studied of those models. Safe care, family connections, solution-based casework, which is actually not just specific to in-home, but is a casework model that applies very well to in-home. And MultiSystemic Therapy, the child abuse and neglect version of that. What I'd like you to do, if you would, is look, you have a table of these elements, and I'd like you to turn to that. It doesn't exactly have a title, but across the top it says 5 models of family-centered in-home services. And I just want to talk a little bit about each model. So intensive family preservation services, many of you are familiar with those. Characteristics of the model include intervention within 24 hours of referral, 24/7 availability of someone, often in a teamed model, 6 to 20 hours per week of contact, which requires a low caseload, but a time-limited period, somewhere between 1 to 4 months. In the original model, that was the model. Now research is showing that there needs to be a step down in most cases to a less intensive model, especially for families that have chronic issues of substance abuse or mental illness. There's close attendance, as I mentioned, to safety planning and contingency planning to keep kids safe, provision of concrete services and supportive services, and a focus on teaching skills in the home. There are several places to look for information about intensive family preservation. We've provided a link that's embedded into this PowerPoint so that you can look at some of those. And we actually did a survey of states back in 2011 with the National Family Preservation Network to see how many states were currently using the home builders type model of family preservation. So in terms of supported outcomes, the research is good. And this was sort of the big thing here, that there's a significant reduction in out-of-home placement associated with intensive family pres. Two big studies that are listed there. There's also there's supported less repeat maltreatment and improvement in social support. Those of you who follow the evidence-based registries, Home Builders has a number 2, which is well supported, supported by research evidence. So it's getting really strong research results. Okay, a second model is called Safe Care. Safe Care is a little different than some of the other models in that it's very structured. It's an in-home model. It's structured around behavioral teaching and modeling that looks at 3 areas: child health care, home safety, and parent-child interaction. So when the worker goes into the home, they have very big targets that they're working on. They have specific skills, specific home activities, everything from putting child locks on cabinets, reviewing home safety issues, coaching around parent-child interaction. It's really very carefully trained. There's a manual. It's 13 days of training, strong oversight by coaches and trainers. The folks that are the Safe Care folks, are really very strong on fidelity, which makes it a little bit, it makes it daunting in some cases for states, but the outcomes are really good. And you can see on the right-hand side, as much as a 75% reduction in child maltreatment, reduced risk factors, reduced parental depression, increased perceived parental social support, more satisfied parents, and the parents find it a culturally competent model, and it does have really good ratings for that, for cultural competence. Safe Care would not be, a state couldn't just say, okay, we're going to do Safe Care and not do other things. For example, this is not a case coordination model, so you'd have to think about a way to either get a private agency to do that or make that just part of what a caseworker did. Illinois is a great example of that. I actually worked in Illinois, so I was involved in this. Illinois, Project Safe Care started out as Project 12 Ways, and it was an Illinois-based model originally. And the Illinois Department of Children and Family Services adopted a number of the goals of Safe Care into what they call a home safety checklist. And it has to be done by every Child Protective Services worker, every foster care worker. Some of the specific teaching goals have been incorporated into work with young parents, with elderly caregivers, a whole variety of places where these sorts of activities have been adopted. It's not a pure high fidelity Safe Care model, but it's an example of the kinds of doing stuff in the home that can really bring good outcomes. So Safe Care is something worth considering, and you can see you can get to the source of that here in this link. Family Connections is another model that came out of the University of Maryland. Diane DePamphilis was the creator of this model, and there have been a number of trials starting in Baltimore, but going in a number of other places as well now. The characteristics of the model are that it's voluntary. Typically, the families are at high risk of neglect, but not currently involved in child welfare, even though that's not always true, and there have been trials done with child welfare-involved families as well. Some important characteristics: a minimum of 1 hour per week direct contact for the first 3 months. Clinical assessments, direct therapy if needed, emergency and concrete services, community advocacy. Supported outcomes include improved physical and psychological care, so there's a well-being outcome, increased protective factors, decreased parental risk factors, such as stress and depression, and decreased externalizing and internalizing behaviors. This model is one that is there are a number of publications. I have listed the the listing in the California Evidence-Based Clearinghouse for Child Welfare as a good place to get more information. Family Connections is a full, it's got all the elements of a model in it that could be used in child welfare. So it does have the case coordination piece to it. So I think that's one of the key things that would be easier to adopt. Solution-based casework, as I mentioned, it's a casework model. It has its roots in solution-based therapy, which is extremely well documented at this point. It uses classic solution-focused questions, collaborative service planning. Workers are really actively engaged in referrals. They don't just send people to get services. They attend initial meetings. They do a lot of active engagement. They use relapse prevention techniques, which just makes that a little different than some models. Solution-based casework is considered a promising practice. It's been rated by the California Evidence-Based Clearinghouse as a promising practice. Supported outcomes, less repeat maltreatment, improvements in CFSR outcomes, which of course is a whole range of outcomes, and then more task completion for parents. This solution-based casework has been adopted as a statewide practice model by both the states of Kentucky and the state of Washington. And that is across the board, not just in-home, but also out-of-home care. So when people are looking for a casework, evidence-based casework model, this is a good place to look. And I think this is our final one, MultiSystemic Therapy, the child abuse and neglect version. Now, many of you will know about multisystemic therapy that was developed as a model to work with youth with behavioral problems, so sort of in the 12 to 17 age range. And it's a family model, family-centered model that looks at the whole family and works to improve behavior. But it's been adapted now for child abuse and neglect populations. And so you can see the model characteristics here. There's not as much research yet on this particular version, but it's backed up by a lot of research on the other side. You can see intensive services, 24/7 availability, small caseloads, provision of intensive clinical services to all family members, and using a team model that involves both a caseworker, a therapist, and a psychiatrist. You can see the supported outcomes on this side. So out-of-home placement is one of the outcomes that you're reduced out-of-home placement, along with some really good outcomes for parents and families. Okay. What we did, and this is not to evaluate the models. I mean, the research experts are doing that. But what we wanted to do was evaluate our elements and see, are we on the right track? If these 5 models have, established evidence for effectiveness, how many of those contain the elements that we developed? Because if there's a fairly good correspondence, then we can sort of think we're on the right track. And so we did that, and you have that. That's why I asked you to look at that table. So you can see from looking at the elements, and I just made a copy of the first page. I didn't show you everything on here. You can go through, and there are descriptions for each one of these models about how this fits. For example, the targeting services, it talks about what the specific populations are that are targeted. So this is for your use. As you think about whether you might look at an evidence-based model, how would that work, and does it make sense with the kind of things that you want to do in your system? Okay, I'm going to stop now and take some more questions if you have any.
Once again, as a reminder, it is *1 if you'd like to ask a question over the phones. We'll pause for a moment. And we'll take our question over the phone. Caller, go ahead.
Miriam Denise again. From all these models, which one is the one that shows less percentage or less probability of a family engaging in services again?
I'm sorry, I had a little bit of trouble understanding that one. You're talking about engagement?
Their engagement.
Okay. Well, there are, so what we looked at is whether there was an emphasis on engagement. I'm not sure if I can answer that question as well as I'd like to over, this might be something, I'll tell you what, I would suggest that we put this in the question and answer session, because I would probably want to go back through and look at each one of the types of programs and see what their outcomes are on that. I'd be happy to do that. Yeah, you're welcome. So just put that in the, we'll write that up in questions and answers.
And we'll take our next question.
Hi. Good afternoon. This is Deborah Porche Usher from the District of Columbia. You mentioned in the Intensive Family Preservation Service an observation that there needs to be a step down for families after receiving that service.
Yeah.
Is there a recommendation from, would you recommend one of these others as a potential step down model?
Oh, that's a good question. Well, certainly multi-systemic therapy wouldn't be the right one, because that's another intensive. I think it probably depends more on the family's particular case characteristics. So, if it's since the areas of substance abuse and mental health are primary areas where the step down has been shown to be needed, I would go with a less intensive home-based model that focuses on keeping the family engaged in relapse prevention. Or, if in the case of mental health, keeps them engaged in mental health services. So just a longer time frame, and I would go up to there's on the non-intensive side, there's not a strong research profile for this, but I'd say 12 months seems to be a pretty good time frame. So I'd be looking at keeping a case open for somewhere between 9 to 12 months for families with substance abuse and mental health issues, with a less intensive model that could look a lot like a solution-focused model, but there's not a particular. We haven't gotten down to that fine level of detail. Is that helpful, Deborah?
Yes, thank you.
Okay. I think the main thing, the research on substance abuse in particular is that aftercare is incredibly important, and that aftercare can look like a lot of different things for different people. If the social support network is strong, there might need to be less formal services. So a lot depends on how well you can connect a family with a network. And that's why it's always so difficult to decide how long a case should be open. But my focus would be on connecting that family with the most formal and informal supports that you could to make sure that you can prevent relapse and keep focused on recovery. Other questions?
Thank you.
And we'll take our next question. Caller, go ahead.
Yeah. Hello?
Sure, go ahead.
Okay. I wanted to ask about the safe care.
Yes.
You mentioned that this was that it's very training intensive.
Yes.
So if a state was wanting to use this, you said that there was one with less fidelity. What did you mean by that, and what?
Yeah.
How can somebody engage in something like that without having to?
Yeah. So I could get thrown off a tall building for saying that. Good night. I think what I'm saying is that there are I know at least one state, which is Illinois, which has taken some of the principles of safe care, which is direct teaching and coaching on child safety, on parenting practices in the home, and have turned those into activity-based casework activities. Mm-hmm. And one model in the intensive family it's called Intact Family Recovery, which is an Illinois model for mothers of substance-affected families. Mm-hmm. Does have some research in terms of positive mental health of moms, but there's not research on that piece. So, but I really, if you could afford it, I would say look at safe care, look at going wholeheartedly into safe care. But if you can't, or you don't think you can yet, I might suggest looking at at how Illinois has incorporated some of the elements. And if I can, the home safety checklist would be a great example of that.
Mm-hmm.
I can place that up on our website along with this presentation, so you can take a look at that. It's been put right into legislation, I think now, or into policy and procedure, so it's available.
Oh, that would be great.
Yeah. I see a couple questions here on the chat, and one of them is, are there models that lend themselves better to providing a range of services based on the risk of families? That is such a good question. And I'm going to talk about that in just a minute, so because I've got some ideas for that. Here's another one. My agency serves at-risk medically fragile children. There are not many agencies like mine in the country. Seeing a family more than once a week would cause families not to accept our services. They already have so much going on. We do have issues with engagement, but mainly seems due to the general chaos the family is undergoing. How can we help navigate those barriers, especially when we are a nonprofit and do not have funding to pay rent or utilities? You know, I think that the best, from what I know about this, is that a solution-focused model is a good model, because it focuses on the family's needs and prioritizes what the family's concerns, and that certainly. So I would have you look at something like solution-based casework. We have actually a model at the University of Iowa called Family Development Specialists, which we've modified for families that have children with high medical and emotional needs. So there's some, I might think about that as well. So the family development models, again, they're really based in the solution-focused approach. You know, intensive models for short term if families are in crisis, but you've already said that more than once a week would be too much. So, yeah, not a more non-intensive solution-focused model I would go with. Okay, any other questions on the phone?
Once again, it's *1. No further questions on the phone.
Okay, a couple in the chat. Are the findings of Safe Care the same for the Safe Care Augmented model? Did I look at that? You know, I'm not familiar with that, so I haven't looked at that. And then regarding training and fidelity, was there an evaluation of the training and fidelity requirements of different services? Oh boy, yes. I mean, each one of these models, with the exception of solution-based casework, which isn't manualized, you know, they have very specific criteria, and that's why I've referred you to the originators of the model. They do have very specific criteria, and that's one of the challenges for folks is, you know, how do you implement with fidelity, which is frankly why we looked at an elements model, because it's hard sometimes for a state agency to go all the way to a fidelity. All right, I'm just going to mention this briefly here about the evidence-based program registries. You have in your packet a list of, it's a little short document that includes our review of one particular of the registries, which is the California Evidence-Based Clearinghouse. These are all available registries to the public, and I've embedded the links in there so that you can click around and see some of these are quite they're quite sophisticated now. You can put in your search terms, and you can get a short list of programs that you might want to look at. And so if you pull this up on your computer and click in, you'll be able to get right to the place you want to get to. We like the California Evidence-Based Clearinghouse because it has it's very close to the populations that child welfare serves, and they actually have a child welfare relevance rating, which is really important. That talks about the high relevance means that they've actually been tried with child welfare involved families where there's been maltreatment, and that's often hard to tease out. So what you see in this table that you've gotten is our review of programs that meet that criteria. It's not, that's going to be, it's going to be constantly out of date. But we found, it took quite a bit of work on our part to go through those and just really look at that. And I think now that this registry, over the time that we've been doing this work, this registry is getting better and better. And so you may very well find your own searches to be more effective than ours. But at least that's a starting point for looking at various types of evidence-based services. And included in these are going to be, and the reason that there is an add-on is that they're really, a lot of them are treatment services, so specific, that problem-specific service that I mentioned. So you've got a child behavior problem that's causing a lot of the family dysfunction, or you have a trauma issue. And so that really focuses, many of these focus on those specific kinds of needs that a family might have. And those are great add-ons to what we might be doing as a core child welfare service. Okay, so I'm going to get back to this question that we had here. And so just sort of thinking about considerations for adopting an evidence-based program. First of all, if you're looking at any evidence-based model, you really have to look at the connection between the approach and your core goals. If they have a specific target population, it's really important to know that. I think one of the concerns, it's a concern that I have certainly, and I'll just speak personally here. As we move to, for example, differential response, as we move to, unless we have good assessments, I think it's so important to have good assessments. We don't want to give families underpowered services. If a service really doesn't have evidence that shows that it works where there's been actually maltreatment, just because a family is going down a family assessment track doesn't mean they don't need a serious service or a more intense service. So I would just really suggest that folks look carefully at target populations before you make a decision about implementing a model. You guys, each agency, each state has big goals. Your state goals, your child and family services goals, your program improvement plans. It's really important to see, is this approach going to fit with that? How well does it fit with your current practice and system? Can you make it work? Do you have enough resources to get to fidelity? Those are all, of course, really important questions to consider. James, I think you might have the controls here. Oops, okay. Okay. Yeah. Sorry. So with respect to the targeting, if you're going to implement targeting, so now what I'm going to look at is recommendations for implementation of these various elements. If you're going to implement targeted services, and obviously the first thing is to figure out what targets you have. What are your population needs? To look at your data. And then to try to develop services that fit the populations and the places that you need these services. States that have done some really good work on this include Alabama, Minnesota, and Colorado. Now Minnesota and Colorado are county administered, so it's a little bit different when you're working with one county. Alabama has a state administered system and collects data from local regions about their resource needs, and they focus on developing services that are targeted to different populations. Many states report success using structured decision-making tools to determine levels of risk and harm, and then you can assign service levels accordingly. So, if you want to target and you've got the services available, obviously you need some way to do that targeting. I'm going to say right now that we don't have a lot of, this is one of the biggest challenges in our field is targeting. So probably I've picked one that's hard to talk about. But a couple of success stories that we found in our work across the states. One is that a model where family resource centers or private agency providers that are under contract with the state implement several evidence-based practices within the single agency. I think Georgia has good examples of this, where you can send a family and they have a variety of different evidence-based practice, each one being implemented at fidelity. And it's easier to do that in a smaller setting than it is across a state agency. New Hampshire has a very interesting approach. New Hampshire has a tiered approach. They have 5 defined levels of service intensity. Those are built into their policy. They certify private providers for each level on the basis of whether they meet the criteria to deliver a certain level of intensity. They try as much as possible to encourage agencies to certify for multiple levels so that families can step up or step down as needed. They have periodic reviews by the state caseworker of where the family is at certain points to see whether they might need more intensive or less intensive services. And so getting back to the question that was answered, how are there models for that is one model for providing services to a range of families based on risk. The idea of being able to step up and step down is really important. Some of the challenges we know, it can be really hard to, even within an agency, caseload size is very specific. Like an intensive family pres caseload might be just 2 to 4 families. What do you do when you have more cases than that, or what do you do when you have less cases than that? So it's one of the big challenges of targeting, and we're just really getting going. But I would suggest looking at New Hampshire. I would suggest looking at some of these family resource centers, and if you want more information, what I want to say is we don't have a lot of time left in our in-home services project. Our funding ends in September, so we're not really in a position to do a lot of on-site TA anymore. But I would be really happy to be providing targeted assistance, information assistance to any of you who would like more information. I'd be very happy to be sending you research studies, anything you'd like that could help you make some decisions about these things. If in terms of recommendations for implementing comprehensive assessments, I think there's a tendency for folks to say, we just need one assessment that will do everything. And I don't know if that's going to work that well, frankly. And we actually found that some of the states that were doing better, one of them used as many as 14 assessments. Now, I know that sounds kind of hard to imagine, but it was working for them. I recommend this study here. This was from the Bay Area Social Science Consortium, and Johnson and her colleagues did a comprehensive review of various assessments. The link is embedded in there, and it talks about a lot of good family assessments if you're still looking for one. Now we know the importance of trauma assessment and how effective trauma treatment can be for families. That's one recommendation I have, is to think about getting a trauma assessment early, because you can really reduce a lot of mental distress with families and kids and parents alike, which will make it easier for them to work on the other service needs that they have. With respect to implementing individualized service planning, I would say look at family team meetings. We had to do a lot of digging to find examples, written up examples of states that were using family team meetings with in-home services. It's one of those kind of ironies that family team meetings were developed, as you know, in New Zealand as a way to keep keep kids in their own villages and tribes. And yet, when we adopted it, we focused a lot on out-of-home placement. We did a report on this. You can get to it from this link. It's on the website. And we focused particularly on 3 states, Ohio, Minnesota, and Texas, that are effectively using in-home family team meetings on in-home service cases. If you're looking to improve engagement based on our research, reasonable caseload size. So that was actually kind of part of an answer to an earlier question. How do you get engagement showing up? And how do you get to show up weekly, which would be ideal? Reasonable caseload size. It's kind of math, isn't it? That would be a really important place to look. And if, realistically, if the state worker can't do it, then, can you have a private agency provider who could provide that thing? But it's actually having that, being able to be there often enough to develop a relationship. Training on engagement skills. It feels like a basic thing, but I know many states are really looking to have training to improve communication, improve assessment, engagement skills. Regular, collaborative, reflective supervision. Supervision is the way that workers learn how to practice social work. And in a parallel process model, the supervisor doing highly collaborative, reflective supervision is really the best way to model engagement skills. Think about providing concrete services early in the case, as we mentioned earlier. Another thing which has been shown to be successful across the country are in various states we looked at. We're having what we call liaisons for special populations, a father liaison, a domestic violence liaison, a substance abuse liaison. In Sioux City, Iowa, there's a Native American liaison, someone that's hired that's not necessarily directly associated with the agency. They get a paycheck from there, but they don't necessarily have to be a worker. But someone who will come along at first contact and establish a relationship and help that family address that specific need. A male contact to visit with the father. Someone who can help someone get into substance abuse treatment. So the idea of the personal relationship, the engagement, is something that a number of states are doing. And they're finding, or at least jurisdictions are finding effective. Another thing is to assist the family to improve children's well-being, connecting them to community-based prevention services. So this is along the lines of the coaching and connecting families with support resources. Assisting families to deal with the children's school, medical, and mental health issues, and early screening for trauma. There's really interesting research in the substance abuse area that show if you offer well child treatment to if you offer a well child checkup at a substance abuse place, you're more likely to get moms to show up. Parents respond to they want to do the best for their children, and trying to combine some services, backpacks, all kinds of things that bring families into services, including direct teaching and coaching, especially along the lines of child development. And I've already talked a little bit about this. Having caseworkers having something concrete to teach, it's been shown by research to be effective, and it also is really rewarding. Workers like having activities like that to do. And we've already talked about concrete services. I know at least one state that has actually gone to the giving credit cards to workers to meet emergency needs, so that can be done quickly, so that it's not such a difficult task to get approval. Another thing, and this is a finding that we found, this last one, family support programs. We heard again and again from state directors that family support programs are important in keeping kids safe, and when we probed further, it often came down to that without family support programs, there would not be the development of community resources for emergency needs, and that collaboration allowed child welfare to focus on the things they needed to focus on by being able to get families connected with family support for those critical basic needs. And here's some suggestions for increasing social support. Okay, I think we are ready for our last set of questions. I wanted to show you I put some additional references in here. I mentioned Marianne Berry and her review of family preservation services, and so I wanted to include that. Anita Barbie and her colleagues have done a really nice article about implementing a casework practice model, and that model was the solution-based casework. And it's a really nice article to help you kind of think through what are the steps of implementing a statewide model. I like the article very much. And then if you want to know more about the elements-based approach to looking for evidence-based practice, I've referenced an article by Richard Barth and colleagues. Okay, what kind of questions do we have in our last 10 minutes? Noah, do you have anybody on the phone?
As a reminder, it is *1 if you'd like to ask a question. We'll pause for a moment.
While I'm waiting for that, I have a question from on the chat. Could some of these models better fit larger systems and some better fit for working with families? I'm not sure if I know how to answer that. I think we've sort of already addressed the models for larger systems. I think larger systems have advantages and disadvantages. Larger systems are hard. It's harder to get any one thing going for everybody. At the same time, you tend to have a lot more resources and at least agencies that are around that might be able to go into those specialized evidence-based practices. So I think something like a solution-based casework could be your overall model. States like Missouri have started out at least doing intensive family pres as a state model. They had a lot of success with that. They've moved more away from that lately for different reasons, but they were able to maintain caseloads of intensive family preservation within a state agency. So there are examples, and if you want some more specifics, write or call me, and I can point you to some states that might be able to help you. A question about specific coaching activities that are more effective than others. I'll answer that on the question and answer and give you some specific studies for that. Any questions on the phone, Noah?
We currently have no questions over the phone.
Okay. All right, then I'll close with just a couple of things here. I'm going to need to get can you move the slide for me, James? Try it again. Okay. So this is my offer for help. We have been set up to do free technical assistance. We're not probably at this late date able to do on-site, but we would be very helpful to help you find more resources to do any off-site consultation that we could with you as you're thinking about evidence-based practice. And if we go to the next slide, I'll show you my contact information. There I am. You can also reach us on the website. We have, and I'll just flick over to the website. Well, I don't think you're not going to see mine, but we do have a website that has a lot of information. I don't know. Can you see that? So I encourage you to look at the website. But most of all, just write or call. I'd be very happy to help you with anything I can. Well, I thank you very much. I know this has kind of been a long haul, and I really appreciate your time and attention. Please let us know if we can be of more help, and good luck to you in your implementation of evidence-based in-home services. Take care.
And this does conclude today's conference. Thank you for your participation.